everyone. Welcome to day 9 of Acharya Rad Connect 2025, a premier online webinar series organized by Department of Medical Imaging Technology, Acharya Institute of Allied Health Sciences, in association with Indian College of Radiological Technology. I, Muriel, will be your host for today. I hope you are all doing well and excited for today's session. It is my pleasure to introduce our esteemed speaker for today, Mr. Kaushik Nayak. Sir is an assistant professor in the Department of Medical Imaging Technology at Manipal College of Health Professions, MAHE, Manipal, Karnataka. With over 5 years of teaching experience, Sir has made valuable contributions to shaping the future of students in the field of medical imaging. In addition to his teaching, Sir has authored 5 publications demonstrating his commitment to both research and education in his field. We are truly fortunate to have Sir with us today, and I'm sure we are all looking forward to hearing him today. A warm welcome to you, Sir. I request you to kindly take over the session.
Thank you. Thank you for giving me this opportunity. And thank you for the warm introduction. So, today I'll be taking a small topic on a Lodo City strategies for optimizing image quality. So, we all know that Lodo City technique is very important in present medical conditions where most of the patients who undergo any open surgeries or any treatment undergo a CT scans, especially even the pediatric patients have started undergoing CT scans. So low dose CT techniques are very useful to minimize the radiation exposure. When we say about low dose CT scans, it is not just about reducing the dosage. It is about maintaining the image quality so that diagnostic accuracy is not compromised. So there are many techniques which we'll see in further slides how radiation dose can be minimized while keeping the image quality or to the diagnostic accuracy. There are many factors which is related to the operator, which is related to the equipment and patient. So low dose CT scan is very particularly important. First is in a pediatric imaging, where a long-stand exposure to ionizing radiation cause a lifetime risk of carcinomas. Lung cancer screening, early diagnosis of small nodules in the lungs can be diagnosed using CT scans, and chronic disease monitoring, where a patient have to undergo periodic or multiple CT scans that is often necessary for the treatment, especially where the patient with the intracranial bleed. Patients have to undergo a CT scan of head once in 6 hours, which increases the radiation dosage to the retina, which can cause the radiation-induced cataracts. So, few advancements in iterative reconstruction algorithms and automated exposure controls and AI-driven image reconstruction algorithms have significantly enhanced the ability to achieve the balance between the radiation dose and image quality. So few radiation commonly performed scans are head scan, thorax and abdomen, whereas the radiation dose are measured in millisieverts. So head scan gets around 1 to 2 millisievert. Thorax or chest CT will get around 5 to 7 millisieverts. Abdomen and pelvis will go around 8 to 10 millisievert. Whole body CT scan, that is from vertex of the skull to mid thigh, will give a radiation dose of around 10 to 20 millisieverts. This is in comparison. If you see the annual background radiation exposure is about 3 millisieverts from the natural resources, that is from the atmosphere. So the factors that affect radiation dose, first is scan parameters. When we say about factors affecting radiation dose, there are two factors. One is direct factor, that is under the control of the radiographer or a radiologist or a technologist who is performing the scan, and indirect factors, that is not cannot be controlled by the radiographer, which is a equipment protocol, equipment set specifications and the patient size. So direct factors can be scan parameters, that is tube current, voltage and exposure time, that is the amount of time patient is exposed for a particular scan. Then the patient size, that comes in an indirect factor which cannot be controlled by the radiographer because the larger the patient, higher the radiation dose. Then the scan region. Scan region, certain body parts require more radiation to achieve clear images, which we'll see in further slides how different softwares can be used to alter the radiation dosage. And use of contrast. Usually, when we give contrast to the patient, multiple different phases or delays needs to be taken. So, which will increase the patient radiation dose. So we'll see about dose optimization strategies, how the dose can be optimized. First is low dose city protocols, like we know, which reduces the patient exposure while maintaining the image quality. Iterative reconstruction techniques enhances image clarity with lower radiation dose. Iterative reconstruction, nowadays the AI-based reconstructions are used. Different vendors are using different softwares or AI-based deep learning-based reconstruction algorithms to reduce the radiation dose, which increases the image quality with minimal amount of radiation. And shielding and positioning. Accurate positioning of the patient is always important when it comes to automatic tube current modulation, that is ATCM. If we don't position the patient accurately in the X, Y, and Z axis, if patient is not in the isocenter of the gantry, it will always increase the patient radiation dosage. Then shielding and positioning, like how the shielding protect the sensitive region like thyroid and breast tissue. For thyroid, always thyroid shield can be given if the thyroid is if the neck region is not the region of interest for the present scan, and if and while doing thorax scans, bismuth shielding can be given for to protect the breast tissue from unnecessary exposure to high amount of radiation. Why low dose CT scan is important, like enhancing the image quality while ensuring the patient safety. So, low dose is an advanced imaging technique which helps in maintaining the image quality by optimizing the scan parameters using different types of iterative reconstruction or AI based reconstruction techniques and ensuring the imaging is proper image information is obtained, that is with the diagnostically accurate image information is obtained with the reduced radiation induced risk to the particular patient. So now one by one we'll see how the strategies, how dose reductions can be obtained for maintaining a low dose CT scans. First will be automatic exposure control, iterative reconstruction, tube current modulations, low KEP protocols, and optimal scan parameters. So what automatic exposure control does? Exposure control adjusts the adjusts the MAS according to the patient size. For example, patient size, body region, and tissue density. When a patient or individual is undergoing a neck and thorax CT scan imaging, what happens is during in the neck region, the amount of tissue is very less compared to the amount of organs or amount of bones present in the denser tissues present in the thorax region, especially in the shoulder areas, which requires very high amount of MAS. That is, amount of number of photons should be high to obtain the proper image quality. If higher MAS is not used in that particular region of interest, it causes streak artifacts and reduces the diagnostic accuracy of the images. But the same MAS is not required in while imaging the neck region, because neck region is mainly made up of only one spine, cervical spine is present, and very others all will be a soft tissues present. So immediate change in the MAS should be present when the scan is going on between neck and thorax. So this is controlled by automatic exposure controls, which reduces the dosage to the less dense area and while maintaining the enough MAS or enough tube current to the denser regions. Benefits of this automatic exposure controls are it is a personalized dose reduction algorithm. Each and every individual or each and every patient is different. Automatic exposure control software allows us to personalize the amount of MAS or amount of radiation given to the patient based on the patient structure, density of the organs, and how the patient is positioned or the patient's anatomy, which allows us to avoid unnecessary exposure to very high amount of radiation, especially when it comes to lean patient or lean or very thin patient. We don't have to give high amount of radiation. So, or in the wherever the low density organs are present. Low density organs can be mainly near the intestines. Intestines are mainly hollow air-filled regions. So those are all low density regions. Where if we use automatic exposure control, the image quality will be maintained throughout the scanning field of view. If automatic exposure controls are not maintained, the image quality or the image clarity varies based on the difference in the density of the tissues. Especially, for example, like I told, in the city chest, AEC can reduce that is automatic exposure control can reduce the dosage to the lungs, which have the lower density compared to the other bony structures present, especially in the shoulder regions. Then comes the iterative reconstruction algorithm. Hopefully, everyone knows what is iterative reconstruction. It is a complex mathematical algorithms used in the reconstruction of the city images. There are many other reconstruction algorithms like back projections, filtered back projections, iterative reconstructions. Iterative reconstruction is the advanced one. More advanced one, recent advanced ones are deep learning based reconstruction algorithms. But iterative reconstruction allows us to reduce the radiation dose while improving the proper image quality. By lowering the how it reduces the how it maintains the image qualities, it reduces the it reduces the noise present in the images. When the noise in the images are eliminated mathematically with the post processing algorithms, the image quality increases. When we say image quality, it depends on the resolution of the image, contrast density, and how clear the sharpness in the images. Whereas if we use other traditional methods like FBP or filtered back projections, usually filtered back projection requires very high amount of radiation to produce a image with the high diagnostic accuracy. Whereas if we use the same uh, for the same patient, iterative reconstructions are used. It reduces the patient radiation dose and increases the image quality with the very less radiation dose settings. So benefits of the iterative reconstruction algorithms are first is it is reduces almost 50% of the radiation dose compared to other conventional methods that is back projection and filtered back projections. And improve tissue contrast and noise suppression, like I told, it maintains the image quality by reducing the amount of noise present in the image. When the noise present in the image is eliminated, automatically the soft tissue differentiation or the soft tissue contrast is increased, which is mainly useful in a pediatric CT scans where the amount of radiation should be as minimal as possible because most of the organs are still in the developing stage. So until the iterative reconstructions can be used for a pediatric scan or when there is a repeated scan required, like again in the brain trauma cases or in the CCT abdomen where the multiple different phases needs to be taken after the contrast injection. Iterative reconstruction are used with the minimal radiation setting to obtain a proper image quality. Iterative reconstruction can be always also used in the low dose CT scans, especially patients with the high risk individuals of lung cancer. Patients can undergo a low dose CT scan of thorax, which allows them to detect the any small pulmonary nodules present in the initial stages of the malignant cancer development. So, which may when iterative reconstruction are used, it also preserves the image quality while reducing the radiation exposure. Tube current modulation. Tube current modulation works similar to in this diagram. So, if you say this is the gantry, how the tube current modulation works. Exactly in the center where the X, Y, and Z axis should meet in the center, where there will be two laser alignment which divides the patient body into anterior and posterior and right and left. So patient's isocenter should be exactly coinciding with the gantry's isocenter. When we position the patient exactly to the isocenter to the gantry, the tube current modulations once the scan is obtained, that is the survey images is obtained. This is a survey image. Based on the survey image, for example, here the system automatically calculates this graph. If you see here, it is made up of shoulder is made up of completely bony regions. So the tube current, that is MA given, is very high. Whereas when it comes to the lung region, mainly lungs are filled with the hollow air-filled cavities, so it reduces. Again, when it comes to liver region is filled with the dense organs, that is liver, kidneys, adrenals, and the so again the radiation, the MA slightly increases, and again the where the intestines are present, that is mainly air-filled cavities. So again, the radiation dose decreases, and when the iliac crest it reaches, it is made with the iliac crest pelvis bones. So automatically, the radiation dose increases. This is one way of the tube current modulation works in three direction. That is in X, Y, and Z axis. So this is automatically the MAS is decreasing, increasing based on the patient's body density or the how the denser organs are present or not. That is mainly in Z-axis. Tube current uh, modulation occurs in two. One is angular tube current and longitudinal tube current. So what now we saw is longitudinal tube current modulation. When a patient, it the MA continuously varies along the Z-axis of the patient. Now, when we say about any individual or patient's body counters are different from individual to individual. But most of the patients, until and unless there is no ascites or any abnormality present, right to left thickness is more compared to anterior to posterior thickness of the patient, individual's torso, except head, where head is totally different, where is anterior to posterior thickness is more compared to right to left thickness, whereas from neck to foot, it is right to left thickness is more compared to anterior to posterior thickness. So what automatic angular tube current modulation does is, till this is longitudinal tube current modulation. Angular tube current modulation does is, when the you all know that patient will be moving when the scan is going on, and X-ray tube and detector will be rotating around the patient. When the X-ray tube rotates from right to left, the tube current decreases because the uh, amount of tissues or a thickness of the human body or the torso is narrow compared to right to left when the X-ray tube is moving from anterior to posterior. So automatically, when the X-ray tube, for example, here if I show in this gantry image, when the X-ray tube is going from this particular angle to this particular angle, the radiation dose, that is MAS, is less because the patient thickness is very narrow from when it is going from right side to left side. When it is going from right side to left side, that is from here to here, patient thickness will be less. Whereas when it is going from anterior to posterior, that is from anterior surface of the patient to the posterior surface of the patient, the amount of the tissue present, that is from right side to left side, very thick amount or a dense tissues will be present in a very the thickness or the amount of tissues or amount of organs present in that particular direction is more. So automatically during angular tube current modulation, the dose varies based on the where the X-ray tube is present. Longitudinal dose, longitudinal tube current depends on based on the organs or the denser the organs or the less dense organ, whereas angular tube current modulation depends on the patient's body contours. It reduces when X-ray tube is going from right side to left side, and it increases when it is going from anterior to posterior or posterior to anterior. So the benefits of tube current modulation is it reduces the radiation dose by up to 40% without any compromise in the without any compromise in the image quality, because the MAS continuously varies across the 360 degree of the patient and in the Z axis. So MAS will be continuously varying in all three X, Y, and Z axis. So based on that, equal amount of radiation will be received by all the organs and proper image quality will be obtained. Like example, like I told, abdomen CT scans where lower radiation is required in the less dense area, that is in the near the intestines, and the increase in radiation near the liver. Here in this particular region, liver, kidney, spleen, and all will be present. Then low KVP protocols. KVP is considered as penetrating power of X-ray. So higher the KVP, higher the amount of radiation reaching the detector. Lower the KVP, lower the amount of radiation reaching the detector. But low KVP protocols are not used for all the patients. Low KVP protocols can particularly used when using the iodinated contrast media. When iodinated contrast media are used and the KVP is reduced, the contrast resolution between contrast and the surrounding tissue is very high compared to high KVP technique. For example, if we keep a 120 kVp and 100 kVp, the contrast resolution is very higher in 100 kVp, because when we are using 100 kVp, the energy or the penetrating power of X-ray is less. So most of the X-rays are absorbed by the iodinated contrast media. So image quality will be, or contrast resolution will be very good. So like it is mentioned here, lowering the tube contrast enhances the soft tissue contrast while reducing the radiation dose, especially when contrast, that is iodinated contrast, not any other contrast media. Iodinated contrast features which causes better attenuation in the lower KVP. KVP is not directly proportional to the radiation dose, whereas MAS is directly proportional to radiation dose. So reduction in KVP reduces the radiation dose only up to 20 to 40%, whereas reduction in MAS reduces the radiation dose by up to 50%. So lower KP protocols are especially used for a pediatric patients or in a thin patients. In pediatric patients, all the organs are not completely developed. So you need to have a better, very good contrast resolution to make sure that no minimal pathologies or no small lesion or tissue, any pathology is missed. So low KP protocols are used in pediatric or in a thin patients, which always improves contrast to noise ratio. Like example is a CT pulmonary angiography for detecting pulmonary embolisms, which helps in where the low KVP is used, and if you are using low KVP means less amount of contrast also can be given, which increases the, because when we are using low KVP, contrast resolution automatically increases. So less amount of contrast also can be used when using the lower KVP techniques. This is how the image resolution varies by variation in the MAS. So this is the image with the high MAS and low MAS. With the low MAS, the amount of number of X-ray photon reaching the detector is less, so image will be grainy. Whereas with the higher MAS, the number of X-ray photons reaching the detector is more, so the image resolution is very high. But when we increase the MAS, the radiation dose also doubles. Then optimal scan parameters. Till now, we studied about KVP and MAS. There are many other parameters that comes into picture when we talk about reducing the radiation dose in low dose CT scan. First can be technical factors like KVP and MAS. Then come slice thickness. When thicker the slice, less the radiation dose. That means where most maximum what we can acquire is 5 slice thickness. Most of the procedures what we do perform, universal protocol is, it will be acquired in 5 and reconstructed into 1.5 and 0.75 increment. Because if we start acquiring the scans in 1 it just increases the patient radiation dose to a factor by 3 or 4. So always it is best to acquire a thicker slice images and reconstruct into thin slice recon images. But the disadvantage is automatically the image details might be lost. When we reconstruct the image, some of the image details are lost. So thicker slice acquisition may compromise the details in the images. Pitch again, pitch is the table rotation per rotation of the table movement per rotation of the gantry. So higher pitch moves faster table movement, which reduces the radiation dose to the patient. But when the faster table movement happens, it reduces the resolution of the images. Then benefit is tailor the scanning to the patient, like each and every patient might have a site. Then comes the collimation. Collimation, narrower the collimation. That means if you focus to the region of interest, you will only have the better image quality. Smaller the FOV, better the image quality. Benefits can be tailored the scanning to the patient needs, like each and every patient will have a different protocol, but which will allow us to do a unnecessary exposure to reduce the unnecessary exposure to patients and improve the image quality. Like example, thin slice imaging in CT brain enhances the detail of the stroke evaluation, but rather than acquiring in 1 mm, you can acquire the images in 3 mm or 5 mm and reconstruct into 1 mm by using iterative reconstruction and reduce the radiation dose by tube current modulation software or algorithms. Advances are first is AI driven image enhancement, and then comes the dual energy city for dose optimization. So AI driven image enhancement is now most of the vendors have started developing the reconstruction algorithms based on deep learning algorithms or the machine learning and deep learning algorithms. So what machine learning and deep learning algorithms does is it enhances the images even by using the minimal to minimal amount of radiation. The information from the image acquired by minimal amount of radiation is enhanced by mainly reducing the noise. Whenever the image information has to be enhanced, means noise needs to be reduced. So by reducing the noise, image enhancement will be done by improving the contrast resolution, that is ability to see the two different structure with a similar contrast, and preserve the fine detail, that is millimeter precision should be less than a millimeter precision should be present in the city images to make sure that none of the uh, pathologies are missed. It is done by mainly different denoising techniques. Each and every individual vendors will have a particular type of softwares to their particular equipments, and different names will be given to them. So what this does is it allows us to reduce the radiation dose to a very significant level, and without any compromise in the diagnostic accuracy of the images. Benefits of this reconstruction algorithms are it enables up to 50% reduction in the radiation dose by mainly by denoising techniques that is used. It helps in the visualization of lesion. That means even the smallest of the smallest lesions can be very clearly visible, especially can be used in the detection of lung cancer screening or a liver cancer or a renal cell carcinomas, where renal cell carcinomas and lung cancer where the tumors can be very small. Whereas in the liver cancer, the tumor will be usually more than a centimeter in length, and particularly low dose lung and like abdominal CT scans. And it also makes sure that reduces the need of repeat scans. Whenever the image quality is poor, we tend to repeat the scans. So AI based reconstruction makes sure that the repeat scan due to poor image quality is completely eliminated because it improves the image quality automatically. So again, example is for low dose CT scans for lung cancer screening, where the same image quality is maintained by conventional high dose scanning. Usually, for a conventional high dose scans, the amount of radiation received is around 5 to 7 millisieverts, whereas in the AI based reconstruction issues means with the 1 to 2 millisieverts, the uh, lung cancer screening can be performed. Dual energy city, where two different sources or two different energy, X-ray energy levels are used. That is, one can be a low kVp and one will be high kVp. Usually 80 kVp and 120 kVp are used. What when we use the different kVp, different tissue has a different linear attenuation coefficient for different energy of X-rays. So when we use 80 kVp and 120 kVp, the amount of radiation reaching the detector will be different based on the composition of the material from which it is passing through. What it does is it helps us to better contrast resolution by lowering the radiation dose than conventional single energy. That is mainly by what it does is it almost eliminates the contrast enhanced studies. When we use two different KVPs and the post processing is done, it tells us what is the material that particular organ or the lesion is made up of, or stone or any calcium is made up of. So it almost eliminates the contrast enhanced studies by, and example is mainly renal stone characterization, where the dual energy helps in the distinguishing between calcium and uric acid stones. Usually, other method of testing is what is the stone composition is by invasive testing, whereas just by two exposure will be required. It is a low KP and high KP. It gives us the exact composition of the stones present in the kidney. Then image quality, mainly there are three resolution. Resolution are spatial resolution, temporal resolution, and contrast resolution. So a spatial resolution, you all know that it is ability to distinguish small structures measured in pairs per millimeter. Like two small structures adjacent to each other should be distinguished as two different structures. Temporal resolution is the ability to capture the fast moving structure that is mainly in the heart or cardiac scan. Then trade-off is whenever higher resolution is required, automatically the radiation dose required will be high, because for a fast image acquisition you need to have a very high kVp and MAS. Especially MAS should be very high for ultra fast acquisition scans. Contrast resolution. Contrast can be two different structures with a similar contrast should be identified as two different structures mainly, and which is contrast resolution is always increased by low KVP technique, like I told in previous slide. When we use a low KVP technique and contrast agent, automatically the contrast resolution increases because of the difference in linear attenuation coefficient of the tissue and the contrast material injected. This is the image where the spatial resolution is calculated, like how many line pairs can be, how many line pairs are present per centimeter. And this is how the different MAS effects. See, in this image and this image, the second image is very sharp compared to the first image because this had a very high MAS settings to it. Then noise, random variations, any variations in the pixel intensity that obscures the image details or any hinders in the image information is called as noise. Especially happens in the low dose CT scans where a low energy X-ray photons might reach the detector and it will be used in the image reconstruction. So always there are different reconstruction algorithms are present nowadays based on the iterative reconstruction and AI based reconstruction. Automatically noise information is removed from the image reconstruction. But whereas higher noise is always lowers the image quality, but will be mitigated by using the iterative and AI based denoising techniques. So how it can be balanced is increasing the dose will reduce the noise and increases the resolution. But always we have to make sure that only when we are increasing the radiation dose, enough diagnostic information is obtained, not to just to get the maximum resolution and the contrast resolution and reduce the noise. Only until and unless the image diagnostic accuracy is maintained, only that much radiation dose can be increased. Lowering the radiation dose always increases the noise, which can be compromised by advanced reconstruction techniques. So how it can be diagnostic accuracy is maintained. Everyone knows LRR as low as reasonably achievable. So radiation ensure LRR principle or a proper proper practice, that is proper until if we know the all the features available in the equipment. Whenever we are using any equipment, we should know the all the features available in the equipment that helps in reducing the radiation dosage to the patient. So that's why LRR principle should be used. But what it does is, say like lung cancer screening, like I told, lower dose is 1 to 2 millisieverts. There only lung cancer screening and conventional lung imaging is totally different. Conventional lung imaging will give you a radiation dose of 5 to 7 millisievert. Lung cancer screening is only done to make sure that there is no any small nodules present in the lung, which can be done by 1 to 2 millisievert radiation. And trauma and oncology scanning, where a standard dose is maintained usually because you need to have a highly detailed images to make sure the proper treatment is given, especially in trauma and patient with the malignancies. Pediatric and high risk consideration, children are always more sensitive to radiation because the organs are in still developing stage. So organs are still radio sensitive. So always use as low as reasonably you can give. That is to the radiation dose to the patient, and they use automatic exposure controls or a 3D dose modulation technique. 3D dose modulation is also a tube current modulation technique, which alters that it's also called as 3D dose modulation technique. And pregnant patients, whenever a pregnant patient comes, always alternative imaging modality should be option should be kept open, like MRI and ultrasound. If and only CT is the only choice of option, then only the CT scan should be performed. Clinical applications can be one is like I told, lung cancer screening. Early detection will help to minimize the radiation exposure with the early detection with minimal radiation exposure. Usually, lung cancer is asymptomatic in early stages and can be and starts to show symptoms after the late stage, or it is already metastarized. So, usually with the high risk individuals, always annually they undergo a low dose CT scans. That is only in the that is always low dose CT scans are used. So, which helps to improve the image quality. Benefits can be reduces lung cancer mortality by early detection, like radiation doses around 1 to 2 millisieverts. Pediatric protocols are children are more sensitive to radiation, like we all I told, their organs are still developing, so the growing tissues or a cell, the cell that is dividing continuously is highly sensitive to radiation. So when we expose those kind of tissues in the early stages, there is a very high chance of lifetime cancer risk because of the radiation exposure in the early pediatric stages. But there are few conditions where the CT scan needs to be performed, like congenital abnormalities, trauma, or there are infections present in the lung or abdomen, where during such situation, the dose reduction technique should be used, which should be very essential. Benefits are up to 60% radiation uh, given to the pediatric patient can be reduced by pediatric specific protocols, which also reduces the cumulative exposure, also reduces the cancer risk associated with the cumulative exposure. That is either by one exposure or multiple exposures by maintaining the high quality images. So techniques can be first is automatic tube current. Always automatic tube current modulation should be used in a pediatric protocol, which helps to reduce the radiation dose to the patient based on the child's size or the body contours. Then again, tube current modulation can be should be used, which dynamically and changes the uh, tube current. That is MAS throughout the scans, which also reduces the radiation dose to the radiosensitive hormones. Example is like in appendicitis cases, usually ultrasound is preferred, but sometimes LDCT can be used for additional confirmation if required for appendix rupture cases. Emergency and trauma cases, rapid imaging with optimized dose. Usually, emergency and trauma, the imaging needs to be immediate and accurate. So, The trauma patient needs to have a immediate imaging for assess the life-threatening injuries, especially head trauma or abdominal blunt traumas. So high dose scans may be unnecessary in a stable cases where you can use a low dose. It is stable cases means with the patient who is able to cooperate with you and follow all the instructions. LDCT helps to optimize the radiation exposure. Benefits are critical information of the vital organs like head, chest, and abdomen injuries can be accessed within the seconds, whereas other imaging modalities might take longer duration. Then reduces unnecessary exposure, especially in mild to moderate trauma cases where only the radiation ensures the radiation is only applied where needed and avoid the overuse of high dose settings to that particular region of interest. Cardiac CT dose reduction can be first. Cardiac CT is very useful in detecting the calcium plaques and soft plaques present in the coronary arteries, which is a life-threatening condition. Just by inserting a cannula to the vein, entire coronary vessels can be studied properly. So always cardiac CT receives a very high amount of radiation because cardiac CT is an ultra fast acquisition. So because it is a heart is a continuously moving organ, so ultra fast acquisition and it requires high resolution because coronary arteries are very narrow vessels. So high resolution ultra fast acquisition requires higher KVP and MAs. So low dose CT scans using different algorithms, that is automatic tube current modulations, with the combination with the different reconstruction algorithms can be used for detecting the blockages in the coronary vessels and acute cardiac assessment will reduce the noises. Benefits are low dose CT scans and low dose cardiac CT, which which gives less than 1 to 5 millisievert radiation while maintaining the diagnostic accuracy. Always helps to improve the patient's coronary conditions like coronary artery blockages can be detected, plaque buildups can be detected, stent patency. If the patient has already undergone angioplasty and stent has been placed in the coronary artery, stent patency after long durations can be uh, identified using a coronary angio coronary angio CT. So, how to reduce the radiation dose? There are two different techniques of ECG gating, whereas the retrospective gating uses higher amount of radiation, whereas prospective ECG gating reduces low amount of radiation and because exposure is only done during the particular cycle of the ECG wave. When the ECG wave is one particular point, only that particular duration the exposure is done, so it reduces the radiation dose to the patient. Whereas retrospective, it is a block scanning and the scanning will be continuously throughout the entire ECG cycle. So lower KVP is used, 80 to 100 KVP can be used because always coronary angio is performed after injecting the contrast. So lower KVP techniques also can be used. Iterative reconstruction minimizes the noise present in the images and enhances the image clarity. Now, then there are many different types of detector configuration can be used. Photon counting CT scans, that is by using a photon counting detectors, which even lowers the radiation dose with better image quality. Coronary CT angiography in young patients with chest pain can rule out coronary artery disease with using the very less radiation as low as 1 millisievert. So in conclusion, low dose CT revolutionizes the medical imaging by providing safer, higher quality diagnostic scans with minimal radiation to the individual. Personalized imaging strategies and technological advancements enhance continuous patient care by improvements by using the automatic tube current modulation and automatic exposure controls. Each patient's based on the patient's size, body contours, and density of the organs, the radiation dose can be personalized to individual. And the strong commitment to radiation safety and image optimization will drive the future of city imaging. Any questions?
If anybody has any questions, kindly post it in the chat box. So we'll answer it for you. So one question has been posted. How can we achieve low kV technique in bone imaging or bone tumors?
Usually for bone tumors, bone cancer, CT scan is not the mode of choice for detecting the bone carcinomas. For bone carcinomas are usually identified using the bone scans in PET CTs or a SPECT CT. Only secondary bone carcinomas can be identified. It can be identified using CT, but with the low KV technique, it is you can use the low KV techniques only after injecting the contrast. Without injecting the contrast, low KV techniques, if you use for bone tumor cases, you will not be able to differentiate much. But the mode of choice is always PET-CT for bone carcinoma. Because in one scan only, you'll be able to identify from head to toe where and all the carcinoma has spread. What is the MAS and KVP used in low dose CT scan? KVP always depends on the patient. It is not exactly 100% fixed. If a lean patient comes, you can use it up to 80 to 100 kV. And 80 kV also can be used if a very lean patient or a pediatric patient comes. Whereas in the normal low dose CT scans, KVP is always 100. Uh, MAS changes. MAS is not constant for any CT scans. MAS continuously changes throughout the CT scans. And what is the difference between automatic exposure control and tube current modulation? What automatic exposure control does is it stops the exposure when the enough number of photons have reached the detectors. Exposure needs to be terminated also. Exposure cannot go on continuously. So what automatic exposure control? AEC is not only used in CT scans, it is used in DRs, mammography, digital mammographies everywhere. So it stops the exposure when the enough information or enough number of photons have reached the detector. Whereas tube current modulation alters the MAS throughout the scan. Tube current modulation alters in based on the body tissue, density of the organs, body counters, and whether it is anterior to posterior when the tube is rotating anterior to posterior or right to left. So when we use the low dose techniques, quality is not up to the mark. So ethically, can it be justified? See, like I told, when we are reducing the radiation dose, we should not reduce it to the limit where we will not be able to see anything. When we are reducing the radiation dose, one thing should be always kept in mind that diagnostic accuracy of the images should not be compromised. Always, first preference is diagnostic accuracy of the images. If so, we cannot reduce it up to the mark that if patient has come, we will give 80 kVp and 100 mAs. That cannot be done. You based on the by looking at the patient itself, you have to adjust the KVP itself. Usually, KVP is adjusted by you, MAS will be adjusted by equipment. How the reconstruction technique help in reducing the radiation dose? Like if you have seen the filtered back projections and all, filtered back projections require very high amount of radiation dose because it is a back projection of the different angle, how the images are acquired. Whereas it is a whereas other reconstruction algorithms like iterative reconstruction. Iterative reconstruction starts with an assumption and makes the corrections of the present acquired city numbers or the information from the detectors to give it the proper image quality. When we do that, automatically the dose is reduced. If we use filtered back projection, the KVP and MAS required is very high. Why cannot we use low dose CT scans for all the cases? The low dose CT scans cannot be used for all the cases. This low dose CT scan is used for screening purposes, not for diagnostic purposes. Like I told, lung cancer patients, lung cancer screening, whether the patient might have lung cancer. Okay. So you just need to know that whether the patient is having lung cancer or not. You don't have to exactly diagnostically tell whether it is a malignant tumor or benign tumor. Only thing when we use low dose CT scan is to tell whether the mass is present in the lung or not. Whereas in a conventional CT scans like contrast enhanced thorax, we cannot do that. When we have to justify the giving contrast, that means we have to tell whether the whether the tumor is malignant, benign, contrast uptake is present or not, whether it is a vascular tumor, avascular tumor, and all needs to be known. So that's why low dose CT scan cannot be used in routine general radiography, where you are just screening the patient, not diagnosing anything. You are just for to making sure that patient might not have a minimum or initial stages of carcinoma or anything, not just you are saying that patient is having carcinoma. Why patient positioning is crucial for reducing radiation dose? Like I have told, X, Y, and Z axis. If your patient is slightly towards the right side, what system detects is patient's right side is highly, slightly swollen or obese. So automatically the radiation dose to that particular region increases. Like I have shown that graph with the abdomen scans. What it does is if the patient is not exactly in the center, automatically that system detects that patient's body contours are not uniform or some problem is present. So that's why it will change the amount of MAS throughout the scans. Whether tube current modulation is used in low dose CT, yeah, tube current without tube current modulation, low dose CT cannot be possible. And tube current modulation is not an option to deselect; it is present in each and every scan. You cannot deselect it. It can only until then unless if you have not selected the proper protocol. Like if the pediatric patient, a 1-year-old child has come and you have selected adult protocol for the scanning, then tube current modulation won't work. You have to manually select it. Or else usually automatically the 3D dose modulation is switched on for each and every scan. How to measure the patient radiation dose intensity? Patient radiation, once the scan is finished, automatically the patient radiation dose information is given by the equipment itself by all the vendors. Whatever vendors you have, those information is given by the equipment. You have to multiply that with the tissue weighting factor and radiation weighting factor to get a proper millisieverts. Usually what you get is based on the information obtained by the equipment. But when we say about the radiation in harmful effects of radiation weighting and tissue weighting factors needs to be kept in mind. So that should be multiplied by the amount of radiation received by the individual. Any more doubt?
If there are no further doubts, I think we can wind up the session. Thank you, sir, for your in-depth explanation of how automatic exposure control, tube current modulation, and all these advanced techniques help to reduce the dose in CT, and also mentioning of how advanced techniques like AI-driven image enhancement, or in certain conditions like cardiac and pediatrics, how the dose can be optimized. The knowledge you shared will definitely help us to make better decisions while optimizing the CT protocols and thus reducing the dose. We are grateful for your time and effort you have put in today for delivering such an informative session with us. It was a privilege to learn from you, sir. Thank you, sir. Before we
Thank
conclude,
you.
let me brief the participants about the next speaker for tomorrow. We have with us Mr. Aditya G. Rao, Assistant Professor, Yanapoya School of Allied Health Sciences, Yanapoya deemed to be University, Mangalore. And Sir's topic is titled Beyond Conventional CT, Revolutionizing Radiology with Spectral Imaging. Once again, our sincere thanks to our distinguished speaker, Mr. Kaushik Nayak, for sharing such invaluable insights to us, and to all the participants for all their active engagement today. We hope that you found the session both informative and useful, and we look forward to welcoming you again tomorrow for an enriching session. See you all tomorrow at 11 a.m. Until then, stay safe, take care, and see you tomorrow.